Welcome to GW Doc Pod. I'm your host, Dr. Andrew Wilner. I invite you to listen in as we discuss advances in prostate cancer treatment. My guest today is Dr. Michael Whalen, Associate Professor of Urology at the George Washington University School of Medicine and Health Sciences and Chief of Urologic Oncology at the George Washington University Hospital. Welcome, Dr. Whalen.
Thanks very much for having me.
Dr. Whalen, thanks for joining us. To get started, can you tell us a little bit about yourself? I read in your bio that you majored in neurobiology at Harvard. Is that correct?
That's correct. So right up your alley. And then I transitioned over to the dark side, as it were. Yeah.
Yeah, it's like, how did you stray from the brain, which is my specialty, to the prostate? There's got to be a story there.
To the second brain, yeah. It's interesting. I was interested in neuroscience as a student and did some neuroscience research. Actually, my senior thesis in college was on Alzheimer's disease and electroencephalographic waveform potentials in response to a paradigm of familiarity versus recollection and in memory. And during my clinical rotations in medical school, in preclinical rotations even, I became interested in oncology and cancer care. And as much as a lot of developments had been made in infectious disease in the early experience of medicine, and then even in HIV research and treatment and successes there, it still seemed that cancer care, despite all of the advances, had a lot more to do and a lot more to develop from a cookie cutter approach to a more personalized and precision medicine. And being in the midst of that was exciting, and using surgery to treat cancer also grew to excite me and to have a proactive impact on patient care. And as much was known, there was even more to understand. So I got immersed in that and grew interested in that and sort of deviated away, I suppose, from neurology. What's interesting is that during prostate cancer surgery, one of the ways to maintain good functional outcomes is to preserve the neurovascular bundle, basically the cavernous nerves that allow for patients to have functioning erections after surgery. So I suppose I haven't completely deviated from neurology altogether, because that is, a huge fundamental component of a well-done surgery. And one of my mentors used to say, Dr. Tawari, who does high-volume robotic prostatectomies at Mount Sinai in New York, used to say that this is one of the few operations where we are judged not by what we take out, but by what we leave in. We want to leave the nerves alone, basically. So yeah, I think it was it sort of dovetails with Biden's moonshot to, cure cancer. And it's a huge impact not only on patients, but also their families. I mean, 1 in 3 men will be diagnosed with cancer, 1 in 2 women, and 3 of the 6 most common cancers in men are urologic: prostate, bladder, and kidney, in that order. So in terms of using my knowledge set to treat cancer and cure cancer, in general, urology poises me at the forefront to be able to do that.
Yeah, well, that's fantastic. And that was my second question is how common is prostate cancer? And it's 1 in 3 men? I mean,
exactly. So 1 in 3 men in general will be diagnosed with any cancer in their lifetime. I think that's a statistic from the American Cancer Society, not urologic cancer necessarily. But prostate cancer is common. It happens in about 1 in 5 or 6 African-American men, about 1 in 7 or 8 Caucasian men, ends up being around 17 or so % of the population. A lot of the cancers that are diagnosed are indolent, and it's also and can be managed, meaning they're slow growing. Because it's such a common disease, we have a lot of experience treating it. Many men these days can be monitored through what's called active surveillance. There's also been studies reported for men who pass away from unrelated causes, heart attacks, strokes, things like car accidents, basically, not from any kind of cancer. But looking at autopsy in the prostate, it's been reported that 80% of them have trace amounts of prostate cancer that might not have been fatal or had any impact on their quantity of life or quality of life. So, it's a very common disease. And there is this notion of, well, if you live long enough, you'll get prostate cancer, and it's not likely to be of any kind of clinical deficit or meaning. But it is also true that prostate cancer is the second leading cause of cancer death in this country, behind lung cancer and ahead of colorectal cancer. And actually, it switched places with colorectal cancer a couple of years ago per statistics provided by the American Cancer Society. And that's partly because of the prevalence of the disease. Only about 3% or so of men will succumb to prostate cancer, but because of the number of patients we diagnose, the total number of people who die actually ends up being the second most who die of cancer in this country. So it's a big public health issue, and from patients and their families issue, also a very important thing to address.
Absolutely. Absolutely. One of the reasons we're talking about this is because when I researched this myself, in fact, years ago, I think there was a friend who had prostate cancer, and I started looking into it, and there just seemed to be so many approaches. Well, you could do nothing, you could do radiation, you could do surgery, you could do hormonal therapy, and it's like, gee, why is this so? I mean, prostate isn't all that big or complicated an organ, it seems to me. So a few questions. In fact, I'll just mention anecdotally, I remember reading a book about Michael Milken and, the junk bond king. And at a relatively young age, I think he was in his late 40s or early 50s, he got prostate cancer. And I remember that he was just personally befuddled. It's like, hey, how come there's not a treatment for this? Everybody gets it. What's the deal? And I believe he created a foundation to pursue prostate cancer research. Are you familiar with that?
Yes, kind of peripherally. I mean, there's a lot of nowadays community support and a lot of foundation. I mean, the Prostate Cancer Foundation, the Movember Foundation. So there's something called Us Too, which is another kind of patient advocacy organization. So there's, a lot of interest, which has grown up because of the prevalence of the disease and people that are thinkers and doers being affected personally and then kind of jump-starting research and development outside of academia or even industry, or partnering with these domains to make more rapid change.
Let's jump back to the science for a second, because I'm curious, and I don't know if we have an answer to this, but what is it about the prostate that enables it or allows it or gives it this proclivity to become malignant? What is it about the organ itself? I mean, we don't see liver malignancies or even kidney malignancies as often as we see prostate malignancies. What's going on down there?
Sure, that's a good question. I mean, the same might be asked about breast cancer, and I don't know that there's necessarily a smoking gun. There's a lot of prostate cancer is hormonally sensitive to the male hormone testosterone. There's likely a multifactorial etiology with genetics and also nutrition. There's a fair amount of cell turnover. I mean, it is producing, secretions, and there are, various chemicals that enter the body, through nutrition or oxidative stress over time, can be concentrated there perhaps. And so oxidative damage can accumulate over time. There is proliferation of the cells over time as well. And this is in response to hormones, intrinsic, and also perhaps, things that people encounter. I don't want to be too conspiratorial about it, but there are associations between prostate cancer risk and red meat and dairy, for example. And, there may be antibiotics or hormones in this meat. So is it inherent to the red meat or the way that the meat is processed? That's not completely known, and it's difficult to study in a way that's not a big population-based study where there's limitations in methodology with, patients remembering how much they've eaten and, not knowing exactly, how the meat was treated, these kind of things. But, it is true that the prostate grows over time. It's called benign prostatic hyperplasia. So there's constant cell growth and turnover. And in these cells that are turning over and growing, there is a possibility that this oxidative stress will lead to DNA damage that forms tumors.
All right. So let's move to your particular area of expertise, which is surgery. When do we turn to surgery for prostate cancer?
It's a good question. And there's been a lot of advances in surgical technology since the operation was done back in the 1990s. I mean, Dr. Patrick Walsh from Johns Hopkins pioneered the radical retropubic prostatectomy with an enhanced understanding of anatomy of the neurovascular bundle to afford better outcomes in terms of continence and potency. It used to be that, being diagnosed with prostate cancer, if you had surgery, you were basically permanently wet, incontinent and permanently impotent. These days, because of advances in robotic technology and minimally invasive surgery, we have more sophisticated techniques to not only cure the cancer, but allow a much higher quality of life after these surgeries. So about 95% of men retain their urinary control and are continent. And, there's very high rates of sexual performance preservation after the surgery as well, after a period of recovery. That number, you didn't hear me give a number. I mean, that depends on many factors, as well as, the patient's function beforehand and where the cancer is. We don't want to leave cancer behind. But because of that, the surgery is less morbid, meaning it has less of an impact on the body. There's less complications with the newer technology using the Da Vinci robot. Less blood loss, faster recovery, shorter hospital stay, less pain. Patients are usually up and walking around either the same day or the next day. I tell people they feel like they've done about 500 sit-ups, so it's like sore but not overwhelmingly painful. And with that magnification afforded by the robotic surgery, we're just really able to appreciate nuances in the anatomy, as far as I'm concerned, just were not appreciated previously. I mean, there's been a lot of work in the neuroanatomy of the prostate done by people such as Dr. Tewari, who I was fortunate enough to train with during my fellowship, about understanding, what's important to spare, and what needs to go or what needs to be excised surgically. So because of that, we are able to do sort of more precise anatomical dissections and, preserve the neurovascular bundle if it's safe, really understand the mechanism of continence. There's been even work done on different approaches, something called Retzius sparing approach. So even these days, as much as has been developed, even more innovation kind of coming down the pike about ways that we can optimize this surgery. It's probably one of the most common operations that I do. And in fact, because of the prevalence of the disease, it's one of the most common operations that we do at the hospital.
Wow. Help me understand a little bit about the robot. Everybody's saying we got a robot. What does a robot do?
Sure. So the robot is not autonomous. It's not doing anything on its own. It's not like a self-driving car, kind of put us out of a job. Maybe that's coming, down the pike. But the robot is just a tool that is controlled completely by the surgeon. So it allows more precise control of the surgical instruments, the scissors, the forceps, the things that we use to manipulate the tissue. It is a freestanding machine that is attached to instruments that go through small incisions in the patient's abdomen. And then sort of through almost like a gaming console, the surgeon will control these tools and these instruments. Originally, the idea was for the military to use the robot in battlefield telemedicine to keep people out of harm's way. I mean, that was one thing or one approach. And then in terms of doing telemedicine in long distances, I think there is still a delay in maneuvering of the instruments versus, the vocal commands. I mean, there is an assistant that is required to stand at the patient's side and help to change instruments and afford suction and help with that. So it hasn't really taken off, through telemedicine. But for use, with urology surgery, it's been really a game changer. And I was training during the era where it was just starting to come online. The first robotic prostatectomy, I think, was done in the early 2000s, if not, 2000 itself. Dr. Manny Menon out of the Vaticuti Urology Institute in Detroit was one of the pioneers of this, and I was fortunate to train under Dr. Badani and Dr. Tewari, who trained under him. So I'm sort of third generation on that kind of dynasty. And it's, so I tell patients it's by no means experimental. It's been around for the last 20 years and has really kind of upped the ante in terms of how we can get patients through the surgical period safely and with better outcomes. It's a little controversial in the literature whether the robot affords better continence or erectile dysfunction. I suppose some of that is based on the patient population and the methodology. Well, there is some suggestion of that. And as I said, based on our understanding of the anatomy, it makes sense of why that would be the case.
Sure, and it probably depends a lot on who's driving the robot.
Yes, yeah, there's a certain learning curve that happened. There has been, concurrent with our experience as the general urology community with sort of doing a better job at the surgery, there has been less surgery performed overall for prostate cancer because a lot of men are opting for, and rightly so, active surveillance. It used to be in the early or mid time of the robot, or mid era of the robot, we were doing surgery on anyone who was diagnosed with prostate cancer. The idea being we didn't want to watch it, let it grow and potentially grow out of control. But now we understand that a period of active surveillance or close monitoring for low grade, what would be termed as National Comprehensive Cancer Network, very low and low risk disease is safe. And in fact, more than 50% or so of patients that are diagnosed with the very low and low risk disease can safely be monitored. There are a proportion of patients that will progress to treatment, but that is about 20 to 30% over 5 years or so. it's kind of actively being studied. I mean, we need longer follow-up to know, how many people are going to progress, in 10 and 15 years, because certainly if you're diagnosed in your 60s, you're going to be around, hopefully, God willing, in 15 years. So more to come. But as we've sort of gotten better with the robot, less people are having surgery. But recently, there's been another kind of stage migration where people who do go to surgery, have more aggressive disease. So we're having to react to that because we're doing active surveillance on the less aggressive disease these days. So that cumulative experience over the last 20 years is really paying off now as we are operating on more aggressive cancers, because especially in that setting, we really want to make sure that, all of it is removed.
Well, absolutely. Well, Dr. Whalen, this has been a really great discussion. Just to finish up, if I'm an internist or a family practice physician and I have a patient and I don't know, I do a physical exam and the prostate's enlarged, or I have an elevated PSA, or I think this guy has prostate cancer, what's my next step? What do I do? How do they get to you?
Exactly. So the fastest way, is to make a urology consultation, right? To seek us out. Not only is the PSA is a good screening tool, but as I tell people, it kind of catches some dolphins in with the tuna. It raises a flag of concern that may not actually be there. And in the past, it used to be that we would automatically biopsy people with an elevated PSA. These days, we're able to be more refined in who we determine would benefit from a biopsy by doing other ancillary testing through blood-based or urine-based biomarkers to look for different kind of gene alterations that are associated with more aggressive prostate cancer to really justify who's going to that next step. And then also we have advances in MRI technology that can basically see if there's a tumor in the prostate. The prostate's a small organ, tumors within it are often less than a centimeter. So we have a suspicion score called the PIRADS system that we use to grade lesions within the prostate to determine whether they should be biopsied. But the point is that these days we can be more sophisticated about, who needs to have a biopsy. And those tests are well within the armamentarium of the urology specialist to be able to offer these. And I work hard to be on top of the cutting edge things that are available for our patients so that, we don't have to be doing unnecessary invasive testing for people who don't need it.
Well, Dr. Whalen, I want to thank you for this terrific discussion of approaches to the treatment of prostate cancer.
You're very welcome. Thanks for the opportunity.
That concludes this episode of GW Doc Pod with the George Washington University Hospital. To refer your patient, please call 1-888-4GW-DOCS. That's 1-888-4GW-DOCS. And if you have questions for one of our specialists, please email physicianrelations@gwu-hospital.com. Thanks for listening. Physicians are independent practitioners who are not employees or agents of the George Washington University Hospital. The hospital shall not be liable for actions or treatments provided by physicians.
Individual results may vary. There are risks associated with any surgical procedure. Speak with your physician about these risks to find out if minimally invasive surgery is right for you.